Let me start quickly by telling most of the things that I'm presenting comes from our group in Munich. We just celebrated our 10 years anniversary last October, and there are many. The group is now formed by about 10 postdocs, and the students, some of them are around here. And I don't go to details of each part who has contributed, but all the papers are on our website and all the videos and explanations, so you can see that. But everything almost I present is the work of this team of students and postdocs that we have at Munich. We are going to talk a little bit about the patient and about, in general, the process of medical. My students have heard this many times, so I changed from triangle to square, so there is some difference. So basically, to tell you, how does it work? I mean, I really want to go back to basics. So when you go to the doctor, the first thing the doctors, they do is that they try to create a virtual model of you. And the first thing they do, they start to get information from you and talk to you and create a diagnostic or treatment model that they could then follow. In the past time, when there was no imaging, they were considering your body as a closed system, as in control system. We look at the system, we want to find about that system. What do? We look at input-output. And so the doctors were trying to look into this closed system through all the input-output and see whether they can find out what's wrong inside this system. Sometimes they were also taking information from this system, such as ECG, or they were taking blood tests or urine, saliva. This would be a sample taken out of the system to predict what is going wrong within this system. And sometimes this also becomes a little bit invasive, that they would take a sample invasively, like a biopsy, and then they would try to categorize and create a total virtual model of the patient to be able to make a diagnostics. So thanks to a lot of work in medical physics, during the last century, we started to have medical imaging. I mean, from the very, very beginning, probably the first medical imaging was by Röntgen, and then it started to whole 20th century. Now, it's very, very interesting to look at the history. I don't know how many of you have looked into this history of medical imaging during the last century, and there are really, really interesting points in it. How many of you know the relationship between CT and beetles? One of you at least. So basically, these are very interesting if you look at the history of that. So Hansfield was an engineer working for EMI in the basement in a lab. And he was an engineer back in the 60s. And his manager gave him a device. EMI had some contract with military at that point. And they wanted him to reverse engineer the device. So he started to take X-rays from different views, look at these X-rays, and then try to reconstruct non-destructively that system. And at that point, he came to this idea that now that we have computers, he could also take many, many views and do a full reconstruction. And his first idea was to do it for brain. So actually, the whole story I'm telling you comes from Dave Hawkes, who explained this in a conference or then personally. So what happened is that he went to his manager, and his manager told, make a proposal, and we see. So he wrote the whole proposals, went to manager, and the manager brought it up, and then they told, we don't have money, and this is out of our field. So they suggested him to go to Erlangen and present it to Siemens Healthcare, there's Siemens Medical at that time. Apparently, Hansfield did that and presented the whole idea there in 60s still, end of 60s. And 2 weeks later, he received a letter which was telling that this was very interesting, but they don't think it would have a medical application. And apparently, Hansfield had it on his office until he got his Nobel Prize. But then he went back to his office for another year, working still for different projects, until EMI sold the albums of Beatles and made hundreds of millions. And then they told to all their managers, if you had any project on your shelf, we can now sponsor it. And then the manager went back to Huntsville, and then they started this project, and they sponsored it, and then he did it. So thanks to Beatles, we got that. If you look at ultrasound, how many of you know where the ultrasound comes from? So if you look at the ultrasonography, the reason we have it was more or less Titanic. So when Titanic sank, the whole community was looking for a solution to detect icebergs. And then they started to develop this technology to send sonar and being able to visualize or detect icebergs. And there was a lot of research in that. And then the First and Second World War, in particular with submarines, brought this technology much, much further, because now they wanted to also detect dynamic objects under the sea and objects which were not easy to detect. So the sonography became very, very echography went very far. And it was only in the 60s that people like John Donald started to use that, thought that this could be used for, in particular, gynecology at that time, and obstetrics, and they brought it to this medical. Many, many things. Really, the history is very interesting. For MRI, for example, how many of you have heard about Damadian or Phonar? It's really good to look at a history of science in general. There are probably 3 people who played important role. If we want to take 3, I would say there are 30,000, but 3 of them have done remarkable leading work. 2 of them got the Nobel Prize of Medicine in 2003, which was Mansfield and Lauterbur, but there is also Damadian. So Damadian was the person who was a medical doctor who had a patent in 1970. In that patent, he was telling that nuclear magnetic resonance could be used for detecting tissue, for recognizing tissue. I actually went and read that patent because this is a very controversial subject, whether he has contributed into MRI or not. From my personal view, when I read that patent, I say yes, he definitely had the idea very early. So in 1970, he had his patent. Now, what is interesting is Damadian went to Siemens, GE, and Philips and told them in the 70s, why don't you build an MRI image? And I have these patents. And they were at that time very excited about CT. So all of them were told, no, CT is much better quality and it does everything you want to do, so we don't do. And then he created this company called Phonar, and later, when the powerful magnets came and the beautiful images, they could create gradients and they could create beautiful images of MRI, GE, Siemens, Philips, everyone went into production of MRI. And Phonar Imaging then sued them, and this is biggest lawsuit in our field, actually. And if you look at Wikipedia for Phonar, you will see that GE lost 120 million to Phonar. They lost because they knew about the patent, and then they still created MR without working with them. And then Siemens and Philips arranged out of the court to also pay and do. So I think it's very interesting. All of the humans in this human interaction and society always plays a very interesting relationship. I remember one of also, since it's a summer school, I go cool. One of the best lectures I had was a lecture on history of science of computer vision. I'm actually not computer vision, vision from Aristotle to Kepler and then later Descartes, was at Harvard Medical School with Professor Sabra, not medical school, Harvard History of Science department with Professor Sabra. And it was amazing when you look at the history of vision, such that from the very, very beginning, you had 3 fields in parallel contributing to vision, which was physics, in the old time represented by Aristotle. You had mathematics, in the old time represented by Euclid, And then you had medicine at that time. Platon was the one who was representing it, where there was this beautiful work of Aristotle looking at trying to interpret vision. He was thinking that there is something going out from our eyes and sensing the objects like the laser. Actually, it was not stupid. I read the paper, translated word by word from him, and I don't think most of our master students cannot go against that, argue against that beautiful paper. And then Euclid took all his definitions and concept modeling and then created his 52 axioms, which still is valid in computer vision about shape from shading or shape from projections. And then Platon at the same time took out and did the anatomy and did studies of cadavers at that time. So these three fields, when you look through the history in 10th century, then it was Al-Hasan, Avicenna. Avicenna was the medicine guy, Al-Hasan was the physics guy and a mathematician guy. And this continued all the way up to today. I mean, today we have three communities that work together, work in parallel actually. You have the community of medicine, medical physics, and then you have the community of computer scientists and computer vision and etc. And these three guys, these three communities are interacting with each other. Now, I go back to this continuation. So these guys created a lot of medical imaging. So the doctors, in addition to looking at input-output, and in addition to take tests from the body and analyzing it, they started also to look at images. So they started to take images, and that's why between 1980 and 2000, I would say 2000, and even as we are talking, medical imaging, which was at that time and now is still, means creating huge cameras looking at inside the body. They started to become a major market, a major scientific field, and of course we were focusing on diagnostics. Why? One of the reasons is, of course, diagnostic is always very important, and if you do the correct diagnostic, the rest is easier, and if you do the wrong diagnostic, is bad. However, that was not the only reason. And that's what I'm going to discuss with you a little bit now. One of the reasons was power of computation. And we will see that the conditions or requirement for diagnostic imaging, for preoperative imaging, is totally different than the requirements for intraoperative imaging. And in order for you to totally see what's happening, let's look quickly at what happens if you want to take an MR. So if you take an MR, I don't know, hopefully all of you very young and have not done it. I have done a lot of CT MR during my life. You will do for sure. So a technician brings you, into the MR. This is really typical what you are seeing here. A technician explains you change your clothes, they explain you should not have metallic objects, etc. They put you on the MR bed. It doesn't have to be Siemens, but we get all of our sponsorship from Siemens, so we keep Siemens in the loop. But then they put, the coil, and then they explain you, and they push you into the system. And basically, in preoperative imaging, the requirement of time is only resolution. The faster you do, you can have more dynamic imaging. And patient specificity doesn't exist. Organ specificity exists now, but since it's diagnostic, it's general. And in particular, you see there is a technician, and and then they look at this data in their control room. Now, there are jokes in medical community, and I always like these jokes when at lunchtime in hospital we go with doctors, because they represent a lot of little things. And I don't know how many of you have heard, they say, how do you hide money from a radiologist? Who knows here the answer? The answer is you put it under a patient, because they never see the patient. They are in their office, the technician does the imaging, and then they go on the PACS and they see that the image. And they look at it, and then they do the diagnostics. So this makes it very relaxed. Now, for surgeon, the jokes is a slightly nastier, but it's interesting. They say, how do you hide money from a surgeon? And the answer is you put it in a book. And this is also not innocent. One of the reasons, which now I'm claiming that in the next 10 years would change a lot, is that the impact factor of any paper in radiology or nuclear medicine is at least 7 times the impact factor of equivalent paper in surgery. And the reason is, we will come to that reason in a second. So now this was imaging, diagnostic imaging. You saw the environment. You go there, you change your clothes, somebody explains you, is a technician, it's not very expensive, bring you there, you take your imaging. Now, this is a surgery in a hospital of Munich, which was 1 hour, and I'm showing you part of it and accelerated in a few minutes, in about 2 minutes. But let's look at the whole thing. So, look at this. Everybody is busy. The surgeon is, first of all, is a teamwork. You have the circulator, you have assistants, you have a guy back there that from time to time comes up and says, is everything okay? And you see him in some place, he's also looking at his journal, is an anesthetist, who is very important, the guy in blue behind the curtain. And then this is a surgery, this is a spine surgery from front, because this patient had already a surgery from back, and they do it laparoscopically. And this is Dr. Euler who is doing it. You will see, first they arrange that, then they insert the laparoscope, now imaging starts. Somewhere on the wall, they have a bunch of CT images that comes from preoperative data. The main doctor here tries to see, and he sees that it's better if he's on the other side of the table, and I need my connection. Okay, I hope you paid attention to the video. At this point, you see they bring the X-ray now in. And they come back and take an X-ray, and the X-ray goes on. So if you pay attention here, time is not resolution. Time is a requirement. If that imaging of X-ray that you see, if it would have taken, instead of 1 minute or 2 minutes to set up, they would have not used it. If the endoscope would not give them real-time feedback, they would have not used it. However, when we look at the whole thing, in this whole room, there is something missing. Who can tell me what is missing from this room? That we have it almost anywhere now, but not here. Yes, a user interface. There is absolutely no user interface. In this room, there was a bunch of cameras. I call all of them camera. Whether it's an X-ray camera or an endoscopic camera or an ultrasound camera, they are cameras. There is no user interface. There is no computer managing anything. If you go to a mechanic shop, they are following a workflow on a computer, wherever you go. But in this environment, because of its complexity, super complexity, we still don't have a lot of softwares. We still don't have, and then look at the imaging. Compare to fMRI and DTI and dual source CT and PET CT and PET MR, What do we have here? Our X-ray is almost the same as the one Röntgen invented, maybe a slightly better resolution, and the endoscope is just a camera. It's just a camera, probably, equivalent or a little bit better than your iPod camera. And the ultrasound is still a handheld, primitive imaging, and this cannot continue. Until 2000, we could not do better because our computational power was miserable. So if we didn't have a time that we have in preoperative imaging to process the data, we would not be able to do intraoperative imaging. The best thing we could do was what we are seeing here in this operating room. But since 2000, we can do very fast imaging. We can do high quality imaging. We can do multimodality imaging. However, our scientific community, the medical physics community, our companies, they are all formed along this big market of diagnostic. This is going to change in the next 5 to 10 years, and the big companies, they are all aware of it, because we are now able to do intraoperative imaging. But intraoperative imaging is a totally different ballgame. Since they are not technicians, these are an anesthetist, a surgeon, a crew, the cost of every second is very high. And these guys are actually, now let's go back to my famous triangle, which is now rectangle. So once they have, now they had the model. Now the model of diagnostic was playing a moderate role in preoperative imaging, in diagnostic imaging, because again, if I have a problem, they make me do a upper abdominal MR or CT. It's very general, because still we are defining the diagnostic. Inside operating room, then we are much more depending on the surgical workflow. Because if they want imaging, it's not because they want to do diagnostic. If you are on the, if you're on the operating room and the surgeon doesn't know what he wants to do, basically you should not be there. Usually when you are on the operating room, on the table, they know what they want to do. So the objective of imaging is no more diagnostic. The objective of imaging is to provide the surgeon with real-time interactive feedback. They want to, when some scientists I hear, they say in 10 years we replace the surgeons by a computer or by a robot. I personally believe this is extremely stupid. The reason is why a surgeon needs 30 years of knowledge. There was a question, we are in this advisory board of IRCAD, and Professor Moresco, one of the surgeons, asked me, why your robotic needle placement cannot place a needle? He says, easy. I asked him a question. I told him, when you insert the needle in 2 different patients, a 20 years old sportive and a 70 years old person who has also diabetic and complexity, do you insert it the same way? Definitely not. In simple actions of surgeons, there is 20 years of education and at least 10 years of training before every simple action they do. They are always looking at a global, very complex anatomy, dynamic physiology, patient. Any single action they do is full of information. And that's how you differentiate between a good surgeon and a bad surgeon. Some people don't know, in computer science, it's easy to compute dexterity, how rigid you can do, how well you can cut and drill. And we claim that we are, telling which surgeon is better. This is total nonsense. The best surgeon is not the surgeon who cuts better. That's the best butcher. The best surgeon is the one who can make the right decision dynamically, when he sees that there is not enough blood circulation or if there is a reaction, the best surgeon is the one who can connect the many pieces of the puzzle and make a decision how to proceed. That is the best surgeon. So one basic difference between preoperative imaging, diagnostic imaging, and intraoperative imaging is that we need to have a real understanding, and from my point of view, that goes beyond just understanding, an electronic machine learning-based control of workflow. We have to know what they need at which point, because they are focusing on the patient, and they are trying to use their knowledge, make decisions, do actions, and then see the outcome of their actions, and then continue with their surgery in a very high-intensity performance scenario. And if we want to augment them, if we want to provide anything, it has to fit there. And therefore, a UI, a user interface, usually to the surgeon I say, I'm the user interface guy. We are really the user interface guys. And inside operating room, this is super complex. Because now, if we are trying to do patient and intraoperative imaging, a basic difference with preoperative imaging is now it has to be patient and process specific. I don't want to do the same imaging if my patient is obese or if I have a kid versus an elderly. My imaging has to change. Everything has to change. And even in a surgery, in an intervention, what I need as imaging at the very beginning is different than after I open the patient, is different than in the next step. So it also depending on the procedure. So we need, first of all, to develop the next generation intraoperative imaging. Forget about, we do a lot talking in the 19th and 2000, everybody was trying to use preoperative data, register it to the patient, and then do navigation. This was a very good solution because we didn't have any intraoperative imaging. But doctors don't like to work on a data which is no more valid, a data which is changing. He's cutting. She is inserting a needle. This is not the same data. The preoperative data was good for diagnostic, good for modeling, good for planning. It's not good for doing the surgery. They hate it. They don't like it. They need to have intraoperative imaging. So we need to develop these things, and then some of the requirement, the most important and probably the most difficult one is relevance. Now, what does it mean, relevance? And I talk about it also in the afternoon when I talk about visualization. Inside operating room, they are not interested in general imaging. If they do an image, they want to see something. So can we optimize our imaging for that thing and not for creating a whole CT or for creating a whole MR? I want to see what is the amount of flow which goes into these vasculatures after I'm putting my stent. That's what I'm interested in. I'm not interested in peripheral or X and Y. Can you do a quick, fast, precise reconstruction, which allows me to see that? So one big message for you, for me in the future, what we want to visualize has to be the real cost function for everything we are computing. And this is not happening yet, but I think we will get there, where we say that the surgeon, we know what the surgeon wants to see, and then we optimize the segmentation, the registration, the reconstruction, everything to give him the right visualization. Speed is incredibly important. Flexibility, because one of the reasons I was showing this, and I will show you more, is I will present you a system that we try to bring to the operating room. When I talk about flexibility, you can bring a system and say this system increases your precision of needle placement 10 times. And as a technician, as an engineer, you think they should use it. If it takes them 10 minutes to set up, No chance. If they need to send their crew for an intensive training, and this system does not bring them enough money to double their salary, no chance. It is a group, it is a very complex environment. The flexibility is a part of it. Usability is incredibly important. Reproducibility, of course, and reliability in medical is definitely a key issue. So as engineers, something we were not doing for diagnostic imaging, now we have to do is, if we want to bring new imaging into the operating room, we have to fully model the surgical workflow, fully model every single device that we are bringing into the operating room, and also the human roles. What does it mean? Not just to know, to write down on a piece of paper and things. No, we need to have a digital statistical representation of the workflow based on signals that we get inside the operating room. These signals can be the blood pressure, can be the usage of a coagulation device, can be an imaging device, the usage of an imaging device, can be the usage of a knife, can be the position of the people inside the operating room, can be many things, can be also based on speech or other things. But we need a digital representation, a statistical digital representation of the workflow. We need representation of our modules and user interfaces that we show of any modality inside the operating room, and who is the user. Is the user the anesthetist controlling the pain of the patient? Is the user the surgeon? Is the user the assistant? If it can be, it's good. And therefore, what we need then is a mapping between this digital representation. At time T in the procedure, I need this data, and that's why computer vision now is coming heavily inside the operating room with Kinect and everything. In Mika, you will see some work where with computer vision, non-intrusively, you're controlling the flow inside the operating room. You try to decide at which step they are, what do they need, which information should I visualize. Now, I give you one example of development of a surgery-specific imaging. And this is where we went also all the way to I would say, thousands of surgeries now. It was navigated nuclear probes. So the technology for preoperative imaging that now we are focusing on is single photon emission computed tomography, SPECT. Now, again, I'm going away from just talking about methods. In this case, for me, the complexity is to look at the whole picture from A to Z. That's why also I'm going to show you how it works. And you will see, and I will discuss how changing any part of this flow can impact the outcome.
Technetium-99m in the form of pentacetate ions.
So the first thing they do is there is a radioactive tracer. In this case, it's technetium-99.
But it has a half-life of just 6 hours, and when it decays, it produces gamma rays. The carrier drug is chosen to accumulate in the part of the body whose function we want to study. Technetium-99m is the most commonly used radioactive material in nuclear medicine, as this function medicine is called, but there are others. For example, thallium-201 is often used for looking at heart muscle, and iodine-131 for the thyroid gland. Once the tracer has been prepared, it is injected into the patient. Then it's a question of waiting, typically for a couple of hours, for the tracer to accumulate in the target organs. Now we are ready to create an image using the gamma ray given off by the decaying technetium-99m. And for that, we need a gamma camera.
are important. If you change the radio tracer, you can now make a totally different imaging. With this group in Lowen, for example, they're trying to, we have big budget from Europe to develop tracers who can visualize nerves. And not only to visualize them, to do visualization within operating room. So this part is a game. And now, she was talking about injecting and waiting to a few hours for this go to the right part of the body. To accumulate in the right part of the body, and then the total lifetime was 6 hours, so that gives us a window of a few hours to still visualize it inside the operating room. Now, in a classical SPECT imaging for diagnostic, you would get billions of events while the camera would rotate around the patient, and you would take between 15 and 30 minutes, and then you would do the reconstruction. Such a device for intraoperative imaging, totally useless. It's not interesting, we cannot do a surgery inside that. So what we developed is we used the computer vision again and tracking of a very simple single detector, and then instead of using billions, we started to use 40,000 events or more by tracking this. So instead of, usually for the reconstruction, you get this image, and then more or less you back project it into space, and you try to do either Fourier transform or MLEM or algebraic reconstruction. You try to reconstruct the volume. Now here we started to say, inside the operating room, I cannot have this device. The doctors have a 1D detector that detects the radioactivity. Once they move it around, they get only 2D images, and it's very hard to use it when they have only one number. Now, usually the usual one was making beep, 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 and then a higher frequency when it was something in that cone of viewing. And now the idea was, if I do computer vision and track that, can I do dynamic 3D reconstruction? So we put a system together, a tracking system, a little computer, any gamma detector could be connected to that, a touch screen because we are inside the operating room, the positioning arm, and then since we love augmented reality, we added also a visual camera, optical camera to the infrared cameras for tracking. Then we started to bring it inside the operating room, and this was really a beautiful challenge for us. So there was many coordinate systems. So in intraoperative, the tracking and registration and navigation with optical, magnetic, mechanical tracking, RFID, etc. This all play a very important role, and most of them is just transformations of coordinate systems and modeling. And the whole reconstruction, in this case, I show you the linear systems that we get, is just you have a measurement M, which tells you the amount of radioactivity that you received at a given point with a given orientation of the device. You back project it into your measurement matrix, you create your measurement matrix, and then you have this simple equation which tells you the sum of those sparse numbers that are the amount of activity that exists in each of these anatomical voxels would be the observation I have M at one given point. And basically, you get the observation M, you have the vector, you try to recover the vector X, which is actually the amount of radioactivity that you think is accumulated in every voxels in this volume of interest. This was the representation, so the gamma signal and the user interfaces. I think I talked about most of them. Here, and I show you a few clinical applications that we started with was sentinel lymph node biopsy in breast cancer, primary breast tumor surgery with radio-guided occult lesion localization or radioactive seed localization, sentinel lymph node biopsy in melanoma, and sentinel lymph node biopsy in head and neck. We tried to set it up. We used both augmented reality and virtual reality, and you will see we didn't tell the doctors that this is AR or this is VR. For me, the best AR or VR user interface doesn't have a name. It's just a user interface that you use, and you try to get your information. And if you want to evaluate it, you evaluate it without telling them. Because it doesn't matter, it's an information that you're presenting. So they could either see it in virtual and move their probe and see the distances and the relationship of the nodules, or they could see it directly on the patient. What you see here, you will see more, this is the injection site, so it's not of interest. This is where they injected the radioactive material. And these are the nodules of interest. This is the nodules that you want to excise, or you want to see how far the cancer has been propagated and whether it has already metastasized or not. This is the objective of sentinel lymph node biopsy. So these are the two scenarios that you see. One thing I should explain, the reason that this system was quickly accepted was that the technetium was not injected for us. It was systematically injected in all the patients because they had to do scintigraphy. This was a part of all their diagnostic, so they had to be injected with scintigraphy. We were just piggybacking on top of this and using it for 3D reconstruction. Then what we needed to do is fully analyze the surgical workflow. And at that time, one of my PhD students, Thomas Wendler, who later is the CTO of the company Surgical, he was a PhD student, and he was practically attending every surgery for about a year or two and bringing nuclear information and doing that. And this allowed us to really fully analyze the workflow and find out this imaging, at which point into the workflow we can bring this, and do they have time for it, and would they improve their workflow by doing that? And then we found holes in their procedures where they had to wait for information, and then we made sure that they are not losing much information in even this 2 or 3 minutes, and the setup is important to analyze. So always you do first test everything with phantoms and simulations. You measure everything, you evaluate the user interface, you try to do your best, and then once you have a results, then you move on. And this was our very, very first patient where we started to do the navigation and we started to do the reconstruction. At that time, it was taking 5 to 6 minutes. Now it's under 2 minutes with gamma probe and under a minute with gamma camera. And this was the very first reconstruction. So the injection site and the nodule. Sorry, it has to load. It's Microsoft. Okay, I try to go faster. So then this is a real operating room, and you see how they look at the user interface. They can see and discuss what they want to do, whether they continue, whether this part, these nodules, they want to take them out, and etc. And they plan. So let me jump over these things because of time. These are some examples that I show you. This is the injection site, sentinel lymph node 1 and 2, and post-excision you have the injection site, but you see that the nodules are gone. And then we did a bunch of pilot study comparing to SPECT-CT. We were not expecting to get the same resolution or the same quality of the image, but we wanted to ensure that we are not missing any nodule between SPECT and between Freehand SPECT. So let me go faster. So you define a whole procedure, you have to validate it, you have to get ethical approval, and then you go and compare the two images after registration here, registration, and quantification becomes important for the validation. These were some examples in Bologna, actually. For example, this is a relatively poor example, even though if we see the nodules, but there are ambiguities, this should not be there. Here is a medium result, intermediate results, but it's good. They were happy because they could see this nodule here. This was what they call the perfect results, where they could actually see the nodules and they could localize it in 3D. And what's the advantage is that for the moment, if they don't have this imaging, they would damage a lot the axilla, and the patient would have pain for a long period of time. And now if they do that faster, they can do less morbidity, and the patient would be much more comfortable. In addition to the points that at some point, you will see that they could also miss some of the injections, some of the nodules. So we did a series of the patient and compared the results to planar scintigraphy, which is the state of art, and also using just a gamma probe, not a 3D reconstruction. And what was really interesting was that we went from 72% sensitivity using gamma probe to 91% using the 3D gamma reconstruction. And patient base, we went to 97, and in 20% of the case, which is enormous, the change in therapy happened. When I say enormous, when I was analyzing as engineers, I looked at the paper of the first SPECT CT, and I saw there that the first SPECT CT, their first big study showed that there would be differences for 5% of the cases. And since then, it became a standard of care. So these are a bunch of examples for breast cancer. This was one case which was successful. They had done a good thanks. In these cases, we were not showing them the images. This was just testing if they would have images, would have been changing the workflow. And in one of the cases, this was the 7th patient, they found out that they had left one nodule left when they were not looking at the image. They could have changed it if they were looking at the images. Let me go faster. We then did melanoma, axilla. We started to do radio-guided occlude lesion localization. This is the real region, not the sentinel lymph nodes. And the doctors started to use it for some application that we were not thinking of, is that when they were taking out the actual nodule, before sending it, usually they send it to pathology. They wait about 30 minutes inside the operating room, and then the pathology tells them, have you got enough margin or not? And then they decide to continue or to clean up. In this case, they were putting the specimen on there. They were doing the reconstruction, and if they were seeing a case like this, like the top case, they were starting already to cleaning the room, preparing everything. Legally, they still had to wait for the response from pathology, but they would clean everything and they could theoretically be ready. And in the other case, you could continue if you wanted to do more of this area because you know that there is not enough margin on this side. So in order to analyze the whole thing and do usability, we went to the workflow, we analyzed the workflow, we got a model of the whole things, and then we started to do usability study with, in this case, with a set of users, engineers who were setting up the system.
Our model consists of 3 methods.
So we did a computer vision approach, computer science approach of defining the whole thing, but let me go a little bit faster in this. So we got the feedbacks, and the nice thing was the computer science could allow us to take all the feedbacks, but because of the workflow and map, the domain that we have defined with people, workflow, and devices, we could find out where the feedback comes. What is interesting here is that for a company who is developing the system, of course, they can do improvement in 10 different directions, but they only have limited money. So they have to decide which complaint, which feedback is the most crucial one. And this is very hard because one feedback comes from anesthetist, one comes from surgeon. One feedback is during the surgery, one is at the beginning, one is at the end. How do you evaluate this? This system was allowing this to nicely organize that and find out what is the most important issue to take care of between all the issues to have for the next version of your solution. Then we analyzed about 100 acquisition of real patient, and this was what was interesting, that we didn't tell the surgeon that this is AR and VR, but then we looked at how many of the surgeons, how often they use the VR versus AR. And this was very interesting because almost other than the last one, who always used AR, the other two surgeons, they used in different phases a mixture of AR and VR, and if you look at the whole procedure, it makes total sense. So we analyzed this in details on also for multiple surgeries that the same surgeon had done, and there are trends based on the surgeon, which information they use. Now, why they use AR versus VR? In the first phase, they use a lot VR, because there they want to compute the distances and decide how far they should cut out and how should they go and access the things. And in the second phase, they want to know that the nodules are gone. So AR in the second phase is more natural than VR. Then we started to do fusion of ultrasound and gamma, and our very first work in the lab was back in 2007. There is a Mikai paper there you can see. So the idea was we wanted to see whether ultrasound and gamma, their usage together would make sense. And it actually makes sense. So what you see here is an ultrasound V mode, and unfortunately the contrast is not very good. But not only on 3D, but also on 2D on ultrasound, you see a circle moving around, and if the gamma reading is high, that circle is red, other one, the circle is green, which means that when they see a bunch of nodules, they can quickly decide whether these are radioactive, or whether, which means they're malignant, or whether these are just nodules which are not relevant, or which are benign. So later we started to do that also in 3D. So we were doing the acquisition in 3D, and then once we do the ultrasound, the nodules that we have reconstructed can be seen and then can be combined with the ultrasound. And once we did that, you'll see it in a second with ultrasound, the doctors started to say that this is even more interesting than the full 3D reconstruction, because in about 30 to 35% of the case may allow us to actually not excise the nodule. So here they started to do, this is an example which would be presented in Mikai in 2 months in Boston, where they try to replace the excision of the sentinel lymph node by looking at ultrasound and then at the same time gamma, see them in the same space, and decide, and then do a needle biopsy instead of excising the nodule, and in case the needle biopsy is also positive, not do excision at all. This changed completely the workflow, because the patient would never go into the surgery room. This would be all done in diagnostic room, in the radiology, without going or in women's clinic, without going to any surgery in that case. And this could be this is 2 nodules that in this patient they saw, and now they found out that this one is the one which has activity, and then they can do a guided biopsy instead of doing that. Now, before giving a hand pass to Tim, I just tell you what I will talk about maybe at some point today. We started by defining the intraoperative imaging instead of preoperative imaging. However, we guaranteed many things. We brought flexibility, we brought the requirements of intraoperative, but there was one thing that we could not guarantee, and that was reproducibility. If two different surgeons were doing two different acquisitions, I would get two different reconstructions. If one of them was fast, the other one was slow, if they were not covering the same region, we were giving them visual feedback, but it's not enough. And also, if they do an injection and the reconstruction is done 2 hours after, 3 hours after, 4 hours after, the decay is slower and slower and slower. So you have to adjust your speed, but a surgeon is not a nuclear medicine expert. So it cannot connect these two dots very easily. So from our point of view, from my point of view, flexible intraoperative imaging of future could only happen if it's robotically done. And therefore we went from that to robotic imaging, and we started to do robotic reconstructions. So the gamma, instead of being in the hand of the doctor, was moved by a robotic device. This opens a lot of opportunity. First of all, now the robot can hold a heavier detector and not get tired like the doctor. So therefore, we could move from that to a gamma camera. In addition, with I can mathematically optimize the number and direction of acquisition. We could do it before, but it's very hard to tell to the doctor, go from here to this position, then that position, then that position. It was much easier to them to say, do a uniform acquisition. Now, if I can mathematically compute what is the best next SPECT acquisition, the robot doesn't care. It can do it very fast and go from one point to other point. So we had this beautiful work by Jakob Vogel and Tobias Lasser, which was published in MICAI and MedIA, where we started to do a lot of random computation of the singular value decomposition of our measurement matrix, and tell that the one acquisition which would give me the best additional information is the one which gives more, which changes my singular value decomposition in a way that I'm going to have a better representation of that matrix. And by doing that in GPU, we can quickly let the robot know where to go, so we can guarantee a better reconstruction in a faster time. Then Jose Gardiazabal and Philip Matthias, what they did is they also took the time of injection, and then they did the simulation of decay, and then they were showing that with the robot, they could do an acquisition with the same resolution 4 hours or 6 hours after injection, of course with different speed. It's very difficult to get that with humans. So robotic would allow us to have flexibility, but also reproducibility. With the gamma camera now, also something very interesting happens. As soon as we had the gamma camera, then we could, you have to define the field of view of this gamma camera and calibrate it. And we could now run this a whole overnight to compute on our Phantom the best calibration, because it was now no more held by a human, but by a robot. And then this is the time-adjusted reconstruction. This is the calibration, which can be much, much more precise, and we came from degrees of magnitude in precision using this system, and also speed. So these are some examples, and the full things would be presented at MICAI. How much time do I have? How much negative time do I have? I still have 10 minutes. Okay, cool. So then we started this big project, which this is my dream, but it may happen or not. Together with Siemens and KUKA, we started a project, and also two small companies, Surgikai and Infusion. We started a robotic project where we would like to have a bunch of flexible robots inside the operating room, to do all the imaging, patient and process specific. So create the real imaging of operating room, not getting satisfied with what Röntgen or others did with simple, but bring them to the next level. I show you some example. This work is done by Bernhard Furst and Christoph Hennersberger. And this is a KUKA robot holding an ultrasound. And we are just showing that it could do nicely, in this example, 3D reconstruction. What you see on upper left-hand side is the ultrasound acquisition. And now we can keep the pressure constant and do an acquisition. And then you will see that in a second that we can then get a tomographic reconstruction, a compounding of the whole thing. It's not a tomographic reconstruction, it's a compounding of 3D volume with constant pressure. And we could see that, we can go through it and we can do things. You saw already gamma reconstruction, SPECT reconstruction robotics. X-ray robotics was already there. Still, is this Zigo with KUKA, Siemens together doing robotic imaging. I think is an overkill, but it's definitely the right direction to do robotic imaging. So how the process work in the future? From my point of view, this is what would happen. Very similar for some of you, if you know radiation therapy, the same concept. In CT, MR, etc., you do a whole imaging and you validate it. Radiation therapy has a difference. The difference is that you have softwares for simulation where you do dosimetry, you plan for a single patient, a specific imaging, in that case treatment imaging, and then the patient later comes and get the treatment, his own or her own treatment, but what is validated is the relationship between simulators and execution. We do the same thing. We take the preoperative data, we take the surgical process model, and we simulate intraoperative images from preoperative, and the doctor says, for this surgery, in the phase X, I need this image. For this phase, I need a combination of optoacoustic, X-ray, and CT. For this part, I need to verify, I need an SPECT. And then we compute the inverse kinematics, how these images can be, and this is PhD program, subjects for many PhD students to come. How to get an outcome and compute the whole inverse kinematic of imaging to get the optimal image that they want to get inside the operating room in shortest amount of time. And then we update the patient model by when the patient goes onto the bed, we do a cone beam CT reconstruction, or we do a 3D, 4D Doppler, or we do many kind of different imaging. We register it to preoperative. We update our preoperative planning for imaging, and then we start to do intraoperative, high-level, multimodal imaging. So we had one example that we are following, but the main part, which is a beautiful part, where it includes registration, segmentation, computation of all inverse kinematic, is where the part the doctor says, what do I want to see? And that is going to be our optimization criteria. So for that, we did two things that will appear, one of them in Mikai. We call it desire view. So instead of having the doctors moving the robot, moving the C-arm, moving the bed, now we ask the doctor to tell us, based on the preoperative CT, the doctor just on an iPad tells, this is the view I want to have. This is actually the hand of Dr. Godby at our vascular surgery department later on. As you move, you see on the right-hand side, we did it only for us, for engineers, to see what we are doing, but the surgeon doesn't need to see it. So the idea is that he says, this is the view I want, and we compute the inverse kinematic, and we get those images. Now, thanks to some of the work we are doing, we will also do Kinect reconstruction. We automatically would detect the collision detection, and then we would be able to say this imaging is possible or not. This is Dr. Godby, who after acquisition of CT, he was planning his images what he needed during his procedure, and then the inverse kinematic was computed. But what we want to do is exactly the same thing for ultrasound. This is a beautiful work again done by Bernhard Furst and Christoph Hennersberger, where the preoperative MR is used to define which ultrasound image I want to take. Then a Kinect on the ceiling, which gives us this image on the left-hand side, allows us a full registration with intraoperative scenario. And then the robot comes and takes the ultrasound. The doctor said, I want this B mode at this level because I want, for example, to do a needle placement here. We can't do a one-to-many registration. So we take a compounding of ultrasound, we take the whole volume, and then we do an MR to CT deformable, MR to ultrasound deformable registration. Now we are in the same space between preoperative MR and intraoperative ultrasound. We take the B mode, which was the desired view of the surgeon, and then we define the cone of ultrasound which corresponds to that, and the robotic system would automatically take it for the doctor, and he can be busy with inserting his needle. I am soon finishing in a few minutes. So this is the world first, and I'm very proud of it, the world first intraoperative SPECT CT. So this is, even though the project is with Siemens, we didn't have access to Zigo for this before Mikai in time, so we did it with a Philips. This is a Philips cone beam system, and this is a robotic SPECT. So now we see the calibration when we see that we have only a millimeter error between CT, cone beam CT, and SPECT. Now the system does a cone beam CT. Then, based on that cone beam CT, the robot is automatically defining the optimal trajectory of acquisition to have the best reconstruction of region of interest that is defined on that cone beam CT. And then the robot starts to do the acquisition automatically. And since those are both two systems are in the same coordinate system, no registration is necessary. We have the cone beam, we have the SPECT CT in the same coordinate system. So this is the very first intraoperative SPECT CT which could be done in about 3 minutes inside operating room. We are bringing that also to transrectal and also endoscopy together with a European project where a sensor would be behind the patient, a sensor would go inside the patient. This is the transrectal one. On the top you see here the ultrasound sensor, and here the SPECT sensor, in this case a PET sensor. And then this is actually a very advanced time of flight PET, which not only computes the radioactivity, but it looks at the energy and gets a window of depth, which allows us to get better reconstructions coming from CERN and DAISY in Hamburg. And then we also now trying to bring it into Da Vinci with drop-in probe. I'm going to be fast here. When in next talk, Tim will talk about Da Vinci drop-in with ultrasound. We do follow his path and do that with Da Vinci and a drop-in nuclear probe. So I finish here the first part. In the afternoon, I will talk about visualization after the exciting talks of Tim. But the message, the main message for you guys is that in the next 10 years, there would be a lot of work intraoperative. Now, the basic difference for you is you can no more sit in an office, wait for your advisor to give you data and tell you, oh, use a machine learning algorithm or use a different algorithm to give me a data out of a solution out of this data. Intraoperative, this doesn't work. Because, you know, I wanted to find it on the internet, but there was a nice work in MIT, again in history of science, and by a student from architecture department from Lebanon that I now forget his name. And on top of his thesis, he had the Tinker of Rodin, but this time the Tinker was looking in front. And his whole thesis was research in the 21st century is not going to be like this. You can't do like that. You have so much information to process that you need to think like this. And in medical and in intraoperative, this is totally true. You could be working on an image improvement for 3 years and find out somebody found a dye that he can inject, which actually makes the image processing easy. The other one comes and projects a laser and measures something else and gets the same information. For me, this is not disappointing. This is exciting because this makes our challenges much more. We have more complex problems. When we talk to doctors, we should not try to, make a modeling after the first time you talk to the doctor. I always, believe that if you want, the first time you talk to a doctor, you write down what he tells you, you make a model. The second time you talk, you will see that nothing is similar. The third time, the fourth time is only after a while that you and him understand the problem at some intersection. But don't forget, they have 30 years of knowledge behind what they are telling, and they can't pass you the 30 years of knowledge in one discussion around a coffee. You need to put them on a driving seat and then try to optimize. And don't forget, you have a process from A to Z. And the outcome on the patient is that what is measuring everything. And then, if in this chain, you are in one part of it, you have to be aware of all other parts of it. Because if you do a beautiful segmentation, reconstruction, registration, if the visualization is miserable, the doctor cannot use it. So you have to be more looking into many things, and you have to know that your problems are going to have many parameters. And therefore, they are much more exciting to work on.